So a little introduction, I'm Dr. Everett Lamb. I am the National Clinical Director for Niznik Behavioral Health. I run all our clinical services for all our locations nationwide. And today we are going to be focusing on and working on ethical referral for treatment. I don't know how many of you are currently working in actual treatment, how many of you are in private practice, any of those things, but this is really focused on how do we refer clients from our private practice or from our facilities that don't treat substance abuse into facilities that do treat substance abuse, and what are kind of those deciding factors that help us be able to do that. And not only to be able to do that, but to make the best ethical decisions in doing that. So our goals for today are to define substance abuse. What does actual substance abuse look like versus just use? To identify some assessment tools to assist us in being able to see where in that acuity list they are. And then looking at some ethical considerations around all those referrals, all the what we can treat, what we can't in private practice and in our scope of licensure, the ASAM treatment levels of care and their criteria, and then we'll do a little Q&A. Before we get started, anybody have any questions? All right, then we'll get right into it. So any other questions that you have, guys, please save for the end. I have set aside some time to be able to answer questions. I have set aside some time to be able to actually see if there's some in-depth stuff or other resources that you guys need at the very end. I'm more than willing to go over time for some of you if you have those questions. I set some availability after, but we will be done within the hour. So let's start by actually defining what substance abuse is. So substance use versus abuse. When we're looking at substance use disorders and we're looking at the issue of substance abuse, we have to look at two pieces. It's both genetic and environmental. So 12% of the US is genetically predisposed to substance abuse issues. It is we know this for a fact, it is a genetic anomaly. It's a recessive gene, which is why not everybody gets it passed down to them. So when we look at the DSM-5, what we're actually looking at is what the definition of abuse is, of substance abuse. So substance abuse is defined by continued use, and here's the big caveat, despite problems arising as a result. If we have someone who's using substances and isn't having any consequences from that, it does not meet the DSM-5 criteria for abuse. It might meet for intoxication, it might meet for some of the other diagnostics that we have available, but it does not meet as abuse. So recreational use of substances or medications does not equal abuse. It's one of the things that has happened previously is a lot of people had the idea that if I was using an illicit or illegal substance, which, you know, over time, over my time in the field has changed as we've had more and more states and areas legalize cannabis use, that any type of illegal substance use was abuse. So that is not the fact. It has to have some consequences and results that are causing problems in their daily life. All right, so the DSM-5 criteria for substance abuse breaks down to these, right? So they're using larger amounts than they intend or for longer than they intended. This person said, you know, I'm going to go have 2 beers and they're having 6 beers regularly, when that's not what they're intending to do. That's not what they're starting out with thinking. The inability to cut down or stop. So they want to stop, they want to cut down. That's the other kind of qualifier that we have there, is they want to cut down or stop and don't have that ability. Time spent, excessive amount of time spent in getting these substances, using these substances, or recovering from substance use. Cravings. Big one, problems in work, home, or school, not fulfilling those obligations to the best of their ability due to possibly recovering from substance use there, preoccupation with using substances. And then the last one is relationship problems. We have 11 in total, and these are what we use as the diagnostic criteria, right? So they've been giving up social, occupational, or recreational activities. Repeated use, even when it puts them in danger. This is driving while intoxicated. This is putting themselves into dangerous situations in order to obtain substances. This also goes along with criminal activity in the need to obtain substances, utilizing criminal activity in order to either obtain substances or funds to be able to do that. Physical and psychological problems exacerbated by use. So that could be elevated liver enzymes. For physical would be a good example. Psychological, it could be increased depression. It could be increased anxiety. Tolerance, that it takes more of the substance to get to that desired effect. And then withdrawal symptoms are alleviated by use. So if I start feeling withdrawal symptoms, I can use again. Those withdrawal symptoms are lessened when I use. So these 11 criteria are what decide the severity of the substance abuse, right? So we've got mild, which says they meet 2 to 3 of those qualifiers. That is mild substance abuse. We have moderate, which is there 4 to 5 of those qualifiers. And then if they have 6 or more, it's considered severe. So that is our definition that we are using of substance abuse. That's the DSM-5 definition. That is what we are utilizing when we say, is this client abusing substances? We may have a client who is misusing substances or overusing medications, but that does not constitute necessarily abuse. It definitely is showing us that it's a factor in them possibly moving towards abuse, but if they don't meet those qualifications yet, we can't diagnose that. Yes, I will be sending the presentation out. Our marketing department here at Niznik will be sending that on as well. So, and in addition, we will be doing these monthly with, it won't always be me, but with different of our directors through Niznik. We will be doing a monthly CEU presentation on all sorts of topics. So keep that in mind as well. All right, so for assessment, the assessment goal is diagnosing the severity, is seeing the reality, is getting the information and data that we need in order to kind of check those boxes that we saw in the DSM-5. Is this real? Is it not? So the real process of that is what we call the SBIRT, which is facilitating screening, which is the assessment tool, brief intervention, which is the conversation that we have with that client or patient, and then referral to treatment. We're doing those 2 things to see where we need to refer out to, if we need to refer out. And we'll talk about that when we talk about the ethical considerations. So as far as assessment instruments, I'm showing you guys a handful that are evidence-based, that are absolutely kind of the penultimate of what we actually use frequently in treatment. No bias, but the SASE is kind of the gold standard. That's not my saying. It's just the most used in all the substance abuse treatment assessments. It is by far the most utilized. One of the good things about it, and I have some of the good and bad things in here for each of them. One of the good things about the SASE is it's available for adults, adolescents, in Spanish and in American Sign Language versions. So it really does help cover a lot of those different groups. It's also been, there's been research on all types of different cultural groups that the SASE is actually shown to work for. So it assesses, the reason we like the SASE is, one, it assesses for all substances across the board. It's not specific to just alcohol. It's not specific to just drugs. And it gives us a pretty good idea. Again, none of these tools are perfect, right? But it does give us a good idea of where the client's at. The difficulty with the SASE is it's self-administered. We'll talk about this at the end when we look at some ethical stuff when it comes to the assessment instruments that we have to be aware of. But self-administration, clinical administration, both kind of have the exact same stumbling block, which is underreporting. If you look, I'm sorry, I'm a visual thinker, so I use a lot of analogies, y'all. If I look at anything in my life that I'm not thrilled with, like if someone asks me, how often do you eat ice cream? I'm going to underreport that because it's something that I'm not proud of, right? Substance use is the exact same way. There's a lot of stigma and other pieces that go with that. But the reality of it is most people are going to underreport their use. So it's something definitely to be aware of with all these assessment instruments. So another one is the CAGE. CAGE stands for Concerned, Annoyed, Guilty, and Eye Opener. This is an alcohol only assessment. This one is only certified for age 16 and over. One thing that people like more about the CAGE is that it is clinician administered, and it is a lot of it is by observable behaviors. So it's stuff that's much more difficult for people to be dishonest about, for people to cover up, or some of those physical behaviors. So the CAGE aid is the new version that is the CAGE that's just adapted to include drugs, has the exact same stuff with it as far as like the requirements, age 16 and older. This is alcohol and other substances, and it is also clinician administered. So the Michigan Alcohol Screening Test, aka the MAST, that one is for alcohol use only, but it's for adults and adolescents. It's also self-administered. It is probably one of the most common alcohol tests behind the SASE that people utilize. It is not as reliable as the CAGE is, but it's a lot more easily accessible. I think you can download PDFs of it almost anywhere to be able to administer. The same with the DAS, the Drug Abuse Screening Test. It's just the drug, version of the MAST that was adapted to cover drugs. So it does only cover drug use, and that one's also self-administered. So there are tons and tons. These are just a handful of the most popular ones. There are literally hundreds of different assessment tools out there. So first thing to make sure before we use any assessment tool is to make sure it's evidence-based. A lot of us, myself as well, have been historically guilty of using assessment tools for things that are just easily accessible, right? We get on Google and Google assessment for blah, blah, blah. We find something that's free. We utilize that without actually checking, is it evidence-based? Is it scientifically backed that this is accurate? So the second piece is the knowledge of the assessment limitations. Like we talked about before, is it an alcohol-only assessment? Is it only reliable for people over a certain age? Is it only reliable for people from certain backgrounds? That's where the cultural competency comes in. So making sure that there's culturally competent analytics for that assessment. If I'm working with someone who's from a different heritage than I am, then I'm definitely going to want to know, is this assessment structured so that it is still reliable with people from different cultural backgrounds? And then, like I said before, the understanding of actual underreporting. The understanding that if I ask someone how often they're using or how much they're using, the statistics say that 98% of the time they are going to underreport that, no matter how good our rapport together therapeutically is. Any questions over that? Sorry, guys, I run through the early stuff so that we can spend a lot more time on the rest of this part. All right, so when we're looking at ethical considerations, three big things that we have to look at, and there's a couple of extras in here as well, but the three major things that you're going to want to focus on are: one, the severity of abuse. How severe is the substance abuse? Second, what substance or substances are they abusing? Are they a polysubstance abuser? Are they just using alcohol? And then co-occurring disorders. I had a question in the Q&A. Is there an average to underreporting? It's all over the place. Actually, there's some caveats and outliers that people who are younger in treatment tend to be more honest. People who, I mean, still some dishonesty, but have a lesser level of dishonesty. It is the ages of 16 to 24 that tend to be the most dishonest about use. And the outlier in that is about 15% of them will actually extremely over-report use. We believe it's an ego reaction for them to try to impress whoever with that idea that they're using these, insane amounts of substances, that, their tolerance is way higher than everybody else. Look at how much I can do. So that's one of the things to be aware of too with that population, is knowing that, late teenage, what I could tend to call like college age, late teenage, early 20s, that there is also a handful of people, not a handful, a considerable subsection of that population that's going to absolutely over-report their use. So that they're going to over-report their use. So with that, that's something that we have to be aware of. So co-occurring. And Mick, I use the term dishonest in the framework that it is dishonest. Like, there's a big difference between denial and dishonesty. As we look in research, I mean, there's been a ton of new research on dishonesty come out, especially with substance abuse, since Kubler-Ross's definitions. So dishonesty just means not using factual data, using data that is not fact. So that's the definition that we're utilizing here. All right, so severity of abuse. When we're looking at that mild, they meet 2 to 3 of those DSM qualifiers. What we're going to focus on with that severity of abuse is education and harm reduction. We're going to want to refer those people out if the consequences escalate, right? If they start meeting more of those requirements, they start driving intoxicated, they start having consequences at work, school, you know, those things begin to progress. Then as those progress, what's going to happen is they're going to actually meet the higher level of severity, which is going to change what our route is for them, right? So for mild, the recommendation is education, harm reduction, and then referral if the use or consequences escalate in order to move them into a higher severity. So moderate to severe, we are always going to want to refer out for treatment and possible detox. Referred clients, people who are referred from a treatment center that were previously meeting for moderate to severe, one, we are going to want to make sure that they're not still meeting those requirements as we diagnose. This is for those of you who are diagnosticians, right? Referred clients, we also want to, I always say, hope for the best and plan for the worst, is have a plan in place for a step up if they aren't able to be successful with us at our level of care. They do end up needing a higher level of care, to create a backup plan just in case. A lot of those, the vast majority, I think, I wouldn't say the vast, a lot of those, in my experience, I have not had to use those plans for step backups to treatment, but I always have it in place because I don't want to have to rush to try to get the client the help they need if they're not going to be able to meet that at the level of care they're at. I want to be proactive and make sure that I'm going to be able to transition them. So substance of abuse, we have kind of 4 different acuities, right? So high acuity is alcohol, sedatives, the sedative family. So that's your hypnotics, anxiolytics, and sedatives, and opiates. So these are high acuity for several reasons. One, alcohol and the sedative family, those 2 are the 2 that are physically, medically dangerous for the clients to go through. So they are going to need medical intervention. If we have someone who is using alcohol on a regular basis or frequently, there is a high risk of them having seizure, having heart problems, having breathing problems during that detox process. Whereas with other uses like with stimulants, cocaine, methamphetamine, like there's a risk of overdose with those always. But when it comes to actually stopping use, there isn't a high acuity. They're going to be uncomfortable. They're not going to feel well. But when it comes to medically, there's not a high acuity. So opiates are on here because of the high risk. Opiates are very, very high risk of relapse and very, very high risk of overdose. That risk has gone up exponentially over the past 15 years. As we've seen some of the fentanyl issues. I mean, it was always high risk, but that risk has exponentially increased as we've seen the fentanyl become part of the mix in a lot of opiates, even opiate pills that are bought off the street that aren't manufactured. in a laboratory, in a real laboratory under the FDA guidance, like those as well they've been finding fentanyl, and there's lots and lots of research out there, guys, on the high levels of fentanyl being found in everything from ecstasy on the street to illegal homemade oxy pills to all sorts of other stuff. So it's high acuity because of the high relapse rate. Now, is someone going to die from an opioid withdrawal? No. They're going to feel like they are, and they're going to be in extreme amounts of pain. That's the one thing we have to remember. Opiates are utilized as pain relievers. So once they go off of those pain relievers, everything that they weren't feeling and were numbed out by, like physically and biomedically, is going to come back. So just the ability of having those feelings again and having those nerves be reawoken again, it's kind of like when your foot falls asleep and you start feeling the pins and needles, except they're feeling that all over the place. So because of the very high risk of relapse and very high risk of overdose, it meets the qualifications for our high acuity. So now moderate acuity would be our stimulants and inhalants. So those are moderate acuity. We still want to have most of those people have some type of medical intervention for the first couple of days that they come into treatment, primarily with inhalants, because there are some psychological things that can go along with that as they detox from the inhalants. There are hallucinations, several other pieces that go along with that, which can literally happen with any of those that we've already talked about as well. Stimulants as well, because there is a risk of low blood pressure. So really quick physiological lesson, right? Neurobiology. So our brain wants to be at homeostasis. So if we're using alcohol, sedatives, opiates, which are downers, our brain is flushing itself with the upper chemicals to try to maintain homeostasis, right? So the instant we actually remove the alcohol, sedative, or opiate, our brain continues flushing that chemistry. It raises our blood pressure. It puts us at risk for stroke and all sorts of other pieces, right? Heart attack, all sorts of other stuff. Opposite end of the scale is, to add to that, that's one of the reasons when you see people who will stop drinking for a period of time, they will seem very anxious, very high strung, very, very fidgety, all those things that we kind of imagine people who are on stimulants will look like when they're using stimulants. It will look like that because, again, we've done this so many times that our brain has become used to and is expecting us to continue to put these substances into our body. So it's preparing itself for that and maintaining those internal high levels of natural uppers in our body, right? So the opposite end of that is if I'm utilizing, if I'm a client who's utilizing frequent use of cocaine or methamphetamine, then it's constantly pushing my chemistry up. So what my brain naturally does to try to get homeostasis is flush itself with the downer chemistry, right? To try to get homeostasis. So once you remove those stimulants, then the brain continues to flush with that downer chemistry. So you'll see a handful of things. Number one with most of these is anhedonia. Anhedonia is just the inability to feel joy. Stimulants affect our dopamine receptors more than anything and flush those dopamine stores in our brain. And it's like flushing a toilet. We have to wait for that tank to kind of fill back up. And when they've been flushing it over and over again, it takes quite a bit of time for that tank to get back stable with the amount of dopamine that we need. So things that normally would be fun, the dopamine is not there to flush into our system to tell us those things are fun. So inhalants, it actually is about the chemistry in the brain, shutting down the oxygen. There can be minor, with both alcohol, inhalants, and synthetics, there actually can be some types of cognitive damage, like actual real cognitive damage because of the way that those interact in the brain. So mild acuity are hallucinogenics and synthetics. Synthetics are the things like K2, spice, any of the insane list of stuff that you see, kratom, the kind of gas station synthetics, bath salts we used to talk about, which have kind of gone out of vogue, but those are mild acuity, although during intoxication, they're high acuity. During the detoxification process, once they're not actually on the substances, they are at low risk of having any physiological issues. And then low acuity is cannabis, tobacco, and caffeine. Even if people are actively on these substances, they're not going to be at medical risk. They're not high need. And there isn't really a medical risk from the detox. Now, that being said, with all of these, there are psychological risks. That's one of the reasons that we look at the levels of care and sending them to things like inpatient treatment, so which we'll discuss in a moment. So intoxication versus use disorder. So intoxication means this client is currently under the influence. It's acute. It is a medical intervention, right? For like we talked about, for the high acuity substances, we need to have someone there immediately. If someone shows up that's insanely intoxicated to a session, like we're not going to let them drive home. We need to seek out some type of medical intervention. It depends on your state of practice, right? My primary states of practice are Texas and Florida. So with both of those, we actually have the ability under HIPAA compliance to identify that they are a danger to themselves or others and seek out additional help while maintaining our ethics and integrity. So intoxication is a medical primary issue. We'll talk about this quite a bit. So when we are looking at ethically taking care of these clients with substance use disorder, the hierarchy always starts with medical. Is this a physical issue? That's what we need to take care of first. Then underneath that becomes the battle of, is this psychological primary? Is this substance abuse primary? So is this a disorder or is this substance abuse that's the primary? And that can be very difficult to metal out. So use disorder, they may or may not be currently under influence. Someone can show up who's suffering from intoxication that also has a severe substance use disorder. But the use disorder is chronic. It's not just acute. And like we talked about, there's no medical intervention necessary for those low acuity substances, cannabis, caffeine, nicotine, tobacco. So with use disorder, though, psychotropic intervention may be necessary, right? If we have someone come in who has been abusing methamphetamine for a long period of time or has been abusing alcohol for a long period of time, has severe anxiety, we're going to need to look at some safe ways in order to address that issue. So substance-induced disorders are almost always due to intoxication or what we call post-acute, which means they're just out of intoxication and are in the withdrawal period. So these are primarily actually in order of their prevalence, psychosis, right? So people who utilize uppers may have psychosis, people coming off alcohol may have psychosis, people who are utilizing obviously hallucinogenics are going to have some type of, visual or audio hallucinations, which falls under the umbrella of psychosis. So psychosis is the most frequent substance-induced disorder. Bipolar disorder, we see frequently with polysubstance abusers, people who utilize both stimulants and depressants. So you have someone who's using both cocaine and alcohol, for example. Those symptoms and the things that they describe are going to look very much like bipolar disorder. That's why we have to be so careful about diagnosing these and making sure that we're re-diagnosing any of the mental health disorders that we diagnose early in recovery, because really those diagnoses are not valid until we get them away from the substance and can say that they have not been completely induced by those substances. Best practices from AMA right now is 2 years, that if they have once they've been medically detoxed, that period starts to 2 years. If they are showing depressive symptoms, that we treat that for the first 2 years. And then at 2 years, look at lowering those medications or weaning them off the medications in order to assess and see if the depression was substance induced or whether it actually is a brain chemistry issue. So again, depression, obviously, a big one, anxiety, obsessive behaviors. sleep disorders, and neurocognitive disorders. Neurocognitive are the things that we look at, which are like brain disorders, continued shaking, palsies, things like that, that happen frequently in early recovery, much more frequently than in the general population. So when we look at co-occurring, it goes back to the chicken or the egg situation, right? Research shows us that self-medication is self-medicating an already existing mental health disorder happens in 95% of all co-occurring disorders. That this is that they originally had depression, or they had poor coping skills and anxiety, utilize substances as a coping strategy to overcome those issues or to not focus on those issues, and thus led to a substance abuse issue. That makes sense, everyone? So self-medication, 95%. Now, substance induced is 5% of all the co-occurring, but it can also co-occur with self-medication. It could be that I had depression for years, and then I start using substances, and all of a sudden I start aging out, and next thing you know, I have schizophrenia, which people, again, is a gray area, that it's not really substance induced. It's just that I've reached the age, mid-20s, early to mid-20s, when those tend to appear. So there is some difficulty in actually researching which are substance induced, but we do know completely that there are some cases that have been substance induced. We have people who have no history of mental illness, no history of any mental diagnoses, and after using substances for a period of time, end up with lifelong continued diagnosable mood disorders. So that absolutely does occur. It's just, it really is the exception more than the rule. So most common co-occurring disorders, this is important for us to know for ethical treatment, right? Because if we're just focused on treating these disorders and not treating the substance abuse, both are going to get worse. It's just the nature of it. We have to treat the client holistically. My master's is in social work. I'm very big on looking at the client as a whole picture. So most common co-occurring in order are depression, anxiety, bipolar disorders, post-traumatic stress disorders, personality disorders, ADHD, conduct disorders, and schizophrenia. Schizophrenia is this strange outlier in our research. I, for years, have been a presenter with NIDA, so I am subject to a ton of cool research. And schizophrenia, there's been a ton of substance abuse and schizophrenia research done over the past probably 10 years. And the fact that schizophrenics die at 20 years earlier on average, have a 20-year less life expectancy than people with any other disorder. Also, that in schizophrenia, the rates of substance abuse are in the 80th percentile, and it's over the 90th percentile for people with schizophrenia who specifically abuse tobacco. So it's a really interesting stuff to see, but it really, just the levels of people that when they have that also have co-occurring substance use is through the roof. But again, we have a very small percentage of the population that do suffer from schizophrenia. But again, depression, anxiety, bipolar, PTSD, these are the ones that you're commonly going to be treating and see substance abuse alongside them. So one of the other ethical things we have to be aware of is cross-addiction. Cross-addiction is increase in other substance use. I call it the Coke versus Pepsi problem. If I go to a restaurant and I order a Coca-Cola and they don't have a Coca-Cola, all they have is Pepsi, I don't say I'll have nothing. I use whatever is available. So with cross-addiction, it's this mental block that people have, this kind of unusual reasoning where they think because they're not using the original substance that they felt they had an issue with, it's okay. So the reality is, and we know from the genetics, that there is not a single one of these gene strands that only is predisposed to addiction to one substance. The minimum amount of substance on any of these gene strands that we found is 4. So if you are predisposed to using alcohol, you are also probably predisposed to having addictive issues around sedative, anxiolytic, hypnotics. So your benzo groups, things like that. You are already genetically predisposed to that. If you are genetically predisposed to using opioids, you're probably also genetically predisposed to methamphetamine. Like there's a whole list of these connections that are there. And so we'll see this very frequently, that we'll have someone present to treatment for alcohol, right? They stop using alcohol, don't use alcohol again, but then they begin using cocaine. So they still haven't used alcohol and return to us for treatment for the cocaine use disorder. Then they stop using cocaine and feel really anxious. So then they start using Xanax. And then next thing you know, their Xanax use has gotten to the level of abuse and they have to return to treatment again. I've seen it tons and tons and tons of times. So this is what we're talking about when we talk about cross addiction. Addiction is not to one specific substance. Addiction is to the chemical process that happens in the brain along with utilizing these substances. So that brings us to the other thing with cross addiction, which is process addictions. So process addictions are addictions that create that same chemical response in our brain just through using actions instead of using substances. So there's probably some people here who have been to Vegas and you realize that you can stay up much, much later when you're gambling because there is that dopamine kick, that same dopamine kick in our brain that allows us to stay awake when we are on stimulants. It creates a stimulant effect in it. So the process addictions, primary process addictions are disordered eating, gambling, sex and love, technology. This includes video games, this includes social media, this includes computers, television, shopping, and exercise. All these at a lower level. So if we look at like DA, dopamine accumulants, which is what we use to measure the levels of dopamine. So when someone utilizes methamphetamine, which is the highest, right? So it brings us to about 1,100 to 1,200% of our normal dopamine accumulants that are in our body, the free-floating dopamine, right? If we're using heroin, depending on the amount of use, it can take us up to about 250, right? Well, 250% of our normal dopamine is where we're at when we eat. 250% of our normal dopamine is where we're at when we are in a physically romantic situation with another. So same way with exercise, same way with video games. All these things are risky because they create that same chemical kick. So we have to be aware of these process and looking out for these process addictions as well. So self-harm is kind of a two. Someone just asked if self-harm falls. Oh, it's Jennifer. Hi, Jennifer. If self-harm falls under process addiction, like cutting. So it does. It actually kicks in. So it kicks up our dopamine levels. It also kicks up levels of oxytocin. And it's kind of like that same pressure release that we discuss with people with anger management issues, is it's less about the actual action and more about the come down afterwards that creates a sense of relief and relaxation. So instead of it being like a dopamine kick, it's more of a relaxation kick, right? So it's more of that downer feeling that happens. But yes, there absolutely is an upper, as anyone can tell you, you get injured, your heart starts racing, you start feeling all these other things. That is dopamine, and that is the parasympathetic nervous system like kicking into high gear. Like there is absolutely an internal chemical feeling that goes along with that, but it's two-pronged because not only is there that feeling from the initial injury with non-suicidal self-injury, but there's also that cathartic come down on the other end of it. And that's the way that most of my in SSI, those clients who we used to call cutters, non-suicidal self-injurers, comes in various ways, but that's the way most of my clients have described that, is it is very much like when you get angry and yell and scream and finally get your temper and all the anger out, and then afterwards you feel that kind of pressure valve release at the end of it with that. So that's very much how they've described it. So another thing we have to look at, medically assisted treatment. So medically assisted treatment is there to assist in cravings, detoxification, and post-acute side effects. So when we talk about things like opioid withdrawal, even long-term, and post-acute withdrawal being physically painful, this is stuff to help assist with that. This is to assist with cravings for those with alcohol. It used to be most of the medically assisted treatments were things that were more what we call diversionary, which was that they would cause some type of negative consequence. So I always look back to like abuse, things like that, where you took it, and then if you drank, you had a severe physical reaction to that, right? So the new generation of medically assisted treatment is not, doesn't look like that. So it's also combined with clinical treatment. That's why we call it medically assisted treatment. It's combined with treatment as usual, whatever that looks like, because we talk about MAT and there's a lot of biases and there's a lot of stigma around it, because when we talk about medically assisted treatment, most people think back to the old days with methadone, right? Where you have people who are just on methadone for very long periods of time. It's physically as hard to get off methadone, if not harder than it is to actually kick the opiates. Like there was a lot of negatives around that. With the new generations, most of that has been removed. A lot of the stigma that's still there is stigma that's been created within recovery communities. Self-disclosure, I'm in very long-term recovery myself. I have been for a long time. And I came through, I got sober through 12-step facilitation, which I still participate somewhat in, although some of my views have changed. And that definitely is where that came from, that if I'm taking anything to make me feel different, then then I'm not sober, right? That I'm not clean. And it was true for a long while when I started in the field with people taking medication for mental health disorders. Now that has changed in a lot of those areas. So this isn't just let's give them something else that makes them feel different. This is combined with clinical treatment. This drastically decreases the risk of relapse and especially overdose, right? So the whole point in the development of most of these new medically assisted treatments were to help reduce the risk of people dying. These are designed for temporary use. They're designed to be stepped down, right? They are designed to start out at a certain level to help alleviate that, and over time to step down until the client does not need them anymore. And there's several different types of options of what that actually looks like. Again, this is a medical issue, but this is something ethically that we have to look at. Like, again, we have to put aside personal biases and a lot of those other issues. This is, through our facility, we do some medically assisted treatment for minority of our clients, but for some of our clients that, especially those at high risk of relapse and high risk, several previous treatments, like this is something we offer to pretty much everybody. We have people who want to do it. We have people who don't. We are very open to that. Like whatever someone's personal choice is their personal choice. But it really is ethically wrong for us not to offer these resources and say, I'd rather have you be on nothing and die than to have you on something that I personally may not consider as sober. That's not true for me, but I hear a lot of that very frequently, that this is just, putting a Band-Aid on a bullet hole and they're just going to go back to using. And the research and science, guys, I'm a scientist more than anything. The research and science on this is solid. Like there is no question that it decreases the risk of relapse and drastically decreases overdoses. So this is another thing that ethically we have to look at when we're looking at treatment options. So again, we have to look at our own competency. What's my education? What's my experience? What's my scope of practice? What's the level of client need? What are my biases? So education doesn't just mean like, what degrees do I have? What letters are after my name? Doesn't mean any of that. What it means is how much knowledge do I have about substance abuse? How much of the science do I have down? How much of the research am I doing? What am I doing with continuing education when it comes to looking at what the newest information is? I travel frequently and visit a lot of practices. And when I go, one of the things that I'm frequently amazed at is how old a lot of the research and a lot of information that people are sharing with other people is. I'm amazed at it when I go to conferences. It's one of those things that like best practices are not what was happening 10 years ago. Best practices are not what was happening 20 years ago, right? So it's staying up to date with my personal education in these areas. It's experience. How experienced am I in utilizing some of these treatment modalities and some of the things that, are found scientifically to work best with my substance abusing clients. So if I'm in my private practice, if I'm working with a client with mild substance abuse, I need to make sure that I am experienced and knowledgeable in the treatment modalities that are going to work to treat their, I primarily work with co-occurring disorder and trauma. That I am going to be using best practices to treat both of those issues at the same time. It's not like, well, here's what I like to do, here's what I'm used to doing. It's what is the actual best practice and getting the experience in that. Yeah, getting the supervision in that, getting the training in that. So another competency is scope of practice. This is a frequent thing. We have a lot of people who overstep their boundaries when it comes to scope of practice. If you are an LCDC, you are not a diagnostician. You cannot diagnose in the state of Texas. So other places it's different, but here in the state of Texas, LCDCs are not diagnosticians. So technically for most of our Texas facilities, it has to be done by a licensed psychologist or psychiatrist, medical professional. So is this within my realm? So when I say scope of practice, I don't just mean licensure wise, I mean, is this within my abilities? Have I worked with a client who has a heroin addiction before that is fresh out of treatment and thinking about relapsing? If not, then I'm probably going to need to ethically refer them to someone I know who has more experience in that area or would be a better fit. So also level of client need. This is one of the hard things to define for ourselves, is what is the actual level of care that the client needs? And then again, looking at my own biases, am I against medically assisted treatment? Do I have issues around people who abuse illegal substances? Do I have issues around people who drive intoxicated? Like, what are the personal biases I have? And then getting past those or referring to someone who doesn't have the same biases. So let's look at the levels of care. So ASAM. ASAM is the American Society of Addiction Medicine. ASAM criteria defines the levels of care for inpatient, or not just inpatient, for all substance abuse treatment. So it guides placement, continued stay, transfer, discharge for all of substance abuse treatment. So there are 6 considerations they say we have to look at when we are looking at placing someone for substance abuse treatment. So it's intoxication and withdrawal. Are they at risk of intoxication? Are they currently intoxicated? Are they at risk of withdrawal? If so, we need to send them medically to a detoxification facility. Do they have other biomedical issues? Do they have diabetes? Do they have cirrhosis? Like, what are the other biological and medical issues that are going on with them? So then emotional, behavioral, and cognitive. Are they developmentally disabled? Is it an issue that they're not going to be able to understand? If so, we need to really consider placement options and ask those questions. How severe is their current diagnosis as far as mental, emotional, behavioral issues? Where are they at? So also at treatment acceptance or resistance, are they accepting? Are they interested in treatment, or are they resistant to treatment? Probably the most important, besides the medical issues, is relapse potential. How high is their current risk for relapse? And then the recovery environment. This also includes the discharge environment, the environment that they're going to go back to after they've been placed in a treatment setting. So the ASAM levels of care, level 0.5, which is early intervention services. Level 1 is outpatient. So what most of us think is private practice would be level 1. Level 2.1 is intensive outpatient. Level 2.5 is partial hospitalization, what we call PHP. And level 3 is residential services, what most people refer to as inpatient. And then level 4 is called medically managed inpatient, what most of us probably think of as detox. So let's take a quick look through these levels of care. 0.5 is rare. You will almost never see it. This is early intervention. This is the groups in schools where someone's caught using substances in school and get sent for assessment and education. It's focused on changing the high-risk behavior, focused on identifying signs and symptoms for them. It might include some group or family counseling, but it's primarily psychoeducational. So then we have level 1, which is outpatient services. What we look at is counseling, right? It's for our clients who have low acuity, and it's focused on early cessation of addiction and addictive behaviors. The things that we're seeing that like they are at risk, right? That they're in that mild range where they have, yes, they're having cravings. They want to use this substance all the time. Yes, they're using more than they intend to frequently, but they haven't gotten to the rest of those consequences yet. That's where this area is. So they're, in order to be in outpatient services, they have to be biomedically stable. They have to be accepting of treatment. This is the ASAM criteria, not Dr. Everett's opinion, and able to maintain abstinence or controlled use. And then they have no withdrawal potential. That is the biggest piece. They have no withdrawal potential, then they're still okay. All right, so then we move up to the higher level of care. We're going up, which is intensive outpatient or IOP. So IOP is 9 hours weekly. It includes group therapy and individual therapy. It's important because it allows for a moderate to high transition to environment. So in outpatient counseling, they may be seeing you, an hour a week, 2 hours a week. In IOP, they're there 9 hours weekly. So they have a lot more stability and a lot more therapeutic time, but they're still able to maintain employment. They're still able to participate in their recovery community. They're still able to do all these other things while still having the support of that intensive outpatient. This also includes substance use screening. So urinary drug screenings, maybe blood screenings, however people do that as part of this as well. So for IOP, they need to be biomedically stable, have treatment acceptance, no withdrawal potential, but they're still at moderate to high risk of relapse. So at these lower levels of care, the big issues are, what is their risk of relapse? If they're outside of a structured setting, how likely is it that they're going to go back to using substances? Partial hospitalization is 20+ hours weekly. Normally, for a lot of programs, I know there's different requirements. They're 30 hours a week. It is clients going for 6 hours a day to a facility in order to receive services and then going home in the evenings. Whereas IOP, they're on their own most of the day with 3 hours of counseling, 3 hours of counseling 3 days a week, or 2 hours of counseling 5 days a week. This is a different, much stronger set. So structured environment with increased environmental exposure. So we're discussing, for most people, partial hospitalization is actually a step down from that inpatient residential level of care. So they've gone from 24-hour-a-day care to 6 hours a day of counseling, where they are free in the evenings. They are starting to have more environmental exposure. We'll discuss that here in a second. So group and individual counseling, substance abuse screenings, again, no withdrawal potential, stable treatment acceptance, but very high risk of relapse. And at PHP level, we can begin looking at people who are somewhat treatment resistant. It is not the norm, but we can look at people who are somewhat resistant to treatment at PHP. Very high risk of relapse. If they are not attending partial hospitalization, then it is your clinical opinion that they are probably more than likely going to use again. So then we look at level 3, which is residential services. That's 24-hour care, structured and controlled environment, at hours of the day scheduled, receiving multiple hours of counseling and therapeutic time a day, as well as medical interventions. It is the focus on developing of recovery skills while separated from risk. The importance of inpatient really is that you are taking that client out of the environment to put them in a safe place where there's no drink menus on the tables, where there's no one, selling substances there, where there's not, a refrigerator they can go to and, at the store and buy alcohol. Like all those temptations and all the day-to-day stressors that lead back to frequent relapse are removed. And at the same time, they're developing those recovery skills. So you'll notice going from residential to BHP, we increase those environmental, we can call them triggers, but those environmental issues and the environmental risks slightly higher. They step down to IOP, those environmental risks go even higher. They go to outpatient, and then they're in the environment the vast majority of the time, right? So our last level of care, highest level of care, is is medically managed inpatient detox. This is purely about medical intervention. This is a stable, secure environment. The focus is on getting that client medically stabilized so that they are okay to begin participating at a lower level of care. So this tends to be the shortest level that people are in, because it normally, on average, does not take a ton of time to get people medically stabilized. On average, it's, really it's about 5 to 7 days for any of those like highly acute, high acuity substances. For lower acuity substances, it could be, as short as a day, 2 days, sometimes even less. So when we are putting all this together, what we have to look at is where the client currently is, what qualifications they meet, to see which level of care we need to put them at. If I have a client, private practice client, who is abusing substances and finally begins having some consequences, then if they're not meeting, if they're barely meeting 2 or 3 of those qualifications from the DSM-5, I'm not going to continue to try to do this on my own if those are increasing. What I'm going to do is refer them out, and I'm going to look at which level they qualify for, right? So in a situation where they're stable, they have stable employment, everything's going okay for them, they're just having these issues, then the first thing I would do is, if I feel that they need a higher level of care, is move them to the next highest level of care, right? So I would refer them to IOP. Now, if they're unable to be successful there, then guess what? They obviously need a higher level of care. Now, on the other end of the spectrum, if I have a client coming in who's drinking daily, has lost their job, has received a DWI, their family's no longer speaking to them, then I'm going to send them in for medical detox, because they are not medically stable. We need to send them somewhere to be stabilized. So those questions and those ethical issues come down to us to make those decisions. Now, if I am struggling with, is this the right decision? Is it not? Then I can always go back and use other resources. I can always call a treatment center. That's one of the things that we frequently have people do, is like, I don't know if this person needs treatment or if we need a referral someplace else. Call a place. We do this frequently, like call, we're more than happy to find out. All right, thank you guys so much for your participation. Thank you guys for coming out. We will be sending out the CEUs along with a questionnaire of how we can do this better. I love constructive feedback, love it, love it, love it. So please feel free to fill those out. Make sure you're on the email list to stay updated for our future presentations. We will be doing, like I said, we will be having these monthly moving forward that we will be putting on. And so thank